Hi, welcome back. So here we'll talk about the first soul. Now, having combat all the compounds, the xenobiotics to soluble compounds, then we will talk about how these soluble compounds can be taken out of the body. How do they come invite propagation? We have earlier explained the role of these transporter proteins that are involved in the absorption from the intestine down, even from the absorption from the alveolar cells after inhalation. And we talked about absorption also through the skin cells. So some of them we have already described the active transportation and facilitated diffusions. And this active transportation and facilitated diffusions is actually been helped or facilitated by the membrane transporter proteins. So these membrane transporter proteins are generally classified into two main superfamilies. That is an ATP binding capsid, we call ABC transporters, and solid carrier proteins, we call them LC transporters. And these transporters are expressed in many locations, including the liver, the kidney, the intestine, the brain. But majorly, we made a mention of some major organs where these things takes place, like in the liver, kidney, and intestine. These are the major cases where these things. Now, we gave a lot of examples of this in the liver. We talked about quite a number of transporters like organic anion transporters, organic anion transporting polypeptide. We talked about the sodium chlorocolic acid co-transporting polypeptide, organic cation transporters, all involved in the transportation of these substances from the blood circulation, protobium that came from the intestine, and they can facilitate the uptake into the liver. And inside the liver, this is where we have the phase 1 and phase 2 enzymes. So the phase 1 and phase 2 enzymes can act on some of these some of these xenobiotics, and after being converted to maybe as soluble and easily excretable compounds, they can now be taken out by export transporters. These export transporters, like multi-drug resistance protein, you can see multi-drug resistant family, or multi-drug resistant 1, multi-drug resistant 3, MATE1. You can see ABCG5, you can see BCRP breast cancer resistant proteins. You can see biosalt export from. You can see MRP2, which is a multi-drug resistant protein 2. Etc., etc. So all these transporters, they are involved in transportation of these substances out as export transporters. So where are they taking them out? They are taking them into what we call bioanalysis, which is more or less a site of which this site can be transported and then empty the content inside the vial. Inside the vial, there is a vial drop. So inside the vial is not only the vial salts and the vial acid that is there. You can have some ascortate products from the liver that are all together can be emptied inside the intestine during the digestion. So the vial acid and the vial salts can be used now in the emulsification of part, while the other things can now be excreted out of the body. In the gut, also the same thing happens in the gut. You have some transporters that can be taken, like a peptide transporter that can help in the uptake. And there are lots of all these organic anion multi-drug resistant proteins are highly expressed there. They can take in some of these xenobiotics and the ones xenobiotics. And of course, like we mentioned, there are also an export transporters like breast cancer resistant proteins, multi-drug resistant protein, multi-drug resistant proteins can also after immediately taking in, some of the xenobiotics can be taken out of the body. Especially, I think metabolism. Once they metabolize because of the medication, but these enzymes are also expressed. Both the phase 1 and the phase 2 enzymes are expressed also in the intestine. So also, like we have seen also the phase 3 transporters being expressed there. So you can have also some of these transporters that have facilitated the transportation. You can see multi-drug resistant proteins that facilitate the transportation of these substances out of the enterocyte in the intestinal source. You can see MCT1, and likewise also we can have some of these transporters at the same time also taken in some of them from the blood inside the enteral side. So depending on the condition that favors, if the condition favors, you can even have some of them that are being taken into the portal circulation will also go back to the enterocyte. And from the enterocyte, they can be metabolized and also taken out of the intestine into the gut. And it can probably be excreted or it can come through this enterohepatic circulation. Remember, we talked about how some of these xenobiotics after being converted in the liver can be taken out through the bowel duct into the gut. And inside the gut, we talked about the expression of some of these glucuroneogenesis that can remove glucuronic acid or the conjugated product or conjugated components of some of the xenobiotics, and once the conjugated components we remove, they stand a chance of being absorbed again, and when absorbed again, they can potentially also go back to the liver from the liver like this. This process in particular causes an extension in the speed of these xenobiotics in the system, making them to stay a longer period of time. So, in factors affecting xenobiotic metabolism, we talk a lot about how age affects xenobiotic metabolism, and generally we say the xenobiotic metabolism is very slow at a younger age, and the capacity of these enzymes increase as time, as their age increase. And we say at old age, study shows that there is no decline, particularly that may probably the effect of old age might be related to the problem associated with drug metabolism at old age. We talked about quite a number of enzymes, and I would say there are, even though some studies also show some cytochrome TD6, cytochrome 1E4 to be affected, but most especially some of these enzymes are not actually affected during old age. And we say the old age properties, the characteristic of old age. We talked about hepatic blood flow. We talked about maybe a decrease in the liver size. We talked about decrease in oxygenation due to decrease in the hepatic blood flow. We talked about heart deposition could actually be attributed to the effects of this drug metabolism at old age. Probably some of the causes that some of the reasons that causes decline in the efficiency of metabolism of xenobiotics. And we also talked about the gender, and we said that basically sex hormones, body weight, and fat composition affect the gender, affect the metabolism of individuals, where we talked about activities of cytochrome 2B6 and cytochrome 1E2 to be higher in men than women, while we have cytochrome 3A4 activity being higher in women than in men. And we also talked about pregnancy. In pregnancy, we also talked about basically the role of these hormones that make pregnant and non-pregnant women differ. We talked about the body weight. We talked about fat composition as well, where we also mentioned the activities of the life of cytochrome 2D6, cytochrome 3A4, TB6, TC9 to increase during pregnancy. And on the other hand, we have the activity of cytochrome 182, cytochrome 219 to decrease in the case of prognosis. So we also talked about quite a number of other enzymes and how they are relevant to even this cytochrome 250 monooxygenases and even the phase 2 enzymes with regard to pregnancy. And we also talked about how disease can affect cytochrome, how it affects the metabolism of xenobiotics. And we talked about alteration in hepatic blood flow. We talked about the expression of this drug metabolizing enzyme, both phase 1, phase 2, and even the transporters. We talked about the bile acid production. Generally, this disease condition that can lead to the efficiency in the ability of these organs to produce, for example, bile acid, and how bile acid facilitates the removal of these substances. Of course, if bile acid is never produced, when the substances can remain high in the system, and even high in the system, that affects the metabolism of the drug. And we already explained the polymorphism on several occasions. We talked about the organ transplantation. We talked about the size of the organ being transplanted. We talked about the cases of rejection where we have inflammatory cytokines affecting the metabolism. And we talked about drug interaction. The drug interaction, basically, we talked about induction and inhibition of certain enzyme that can lead to delay in metabolism, or they can potentiate in metabolism, and probably in the case of delay can lead to adverse effect, while in the case of potentiation of metabolism, that is induction, can lead to compounds being ineffective to be clear within a short period of time. So we have given an example of some of these drugs here. Some of these enzymes that have been affected by liver disease, like the cirrhosis. We have cytochrome E1, 2C9, 3A4, cytochrome 180, and VDTs. And these are some of the selected drugs that have been affected in this condition. By the way, this is just an example. And here I have some questions we can try, and you can find the lectures. Some of the lectures, I think, this revision class, and the previous one, the first class recorded. You can find all in this channel. So you can go to, if you have any questions, please do not hesitate and forward. I will have a time to discuss with you. Have a nice day.